Hello, hi, and greetings everyone. This is Dilip once again. So after a short gap of 1 day of rest in between, so I'm meeting once again. So we'll be continuing with the remaining topics of neurology for now. So I think in this session will be of that. So once we finish, we'll discuss about what topic we can do next. So I think we can start with today's session. If you can hear me and see me properly, I think the connection has got re-established better. So I think if you can hear me and see me, then you can just say yes, or probably a thumbs up must be doing just fine. Okay. Of course, yes. Good morning. So let us start with today's session, the session number 1. This is going to be on peripheral neuropathy. So I want to cover on certain important topics like peripheral neuropathy. Then we have, of course, the certain important myopathies are there. Then after that, post that, we'll be having some infectious diseases like meningitis, so which have to cover up. So once I think that is done and we have the final topic on dementia, and I think we can move on further on. I'll be trying to finish as soon as possible. So we are moving on to the peripheral neuropathy, which is a very big topic because we have separate like books on peripheral neuropathy. And Ami is asking what topic after neuro. I will decide. I have not decided yet. So whatever topic you want, I will take after the neurology. Anyways, topics are topics. So peripheral neuropathy. So basically, to start to understand peripheral neuropathy better, you need to really know about the types of the peripheral nerve that is there, and a lot of classification systems are there. There are 2 classification systems. One describes the sensory peripheral nerve classification, and second system describes the overall classification based on the size of the nerves. So, for example, based on the size of the peripheral nerves, you have like A, B, and C. So that's how you classify based on the size of the peripheral nerve. And based on the sensation they supply, based on the sensory system, it's classified into 1, 2, and 3. So we have 2 different classification systems. Based on the size, we have A, B, C, and based on the sensation they supply, we have 1, 2, and 3. And we know the size of the nerve fibers decreases as you move from A, B, and C, which also means that the biggest fibers or the thickest fibers will be the A fibers and the thinnest fibers will be the C fibers, of course. And why the size of the fibers decreases? Because their myelination also is going to decrease, because myelin makes the fibers more thicker, which also means that if the myelin decreases over a period of time, so then your size of the fibers also will decrease, which also means one more important fact, that the C fibers are completely unmyelinated. So the A fibers will be myelinated and the C fibers will be unmyelinated. If they ask you maximum myelination, it's for A. And if they ask you fibers that are unmyelinated, it is C fibers. And the myelin content also will decrease according to the size. So this is how you classify the peripheral nerve fibers, A, B, C, and 1, 2, 3. So let us see the classification in a little bit of detail now. So based on the A classification system, we have A alpha, A beta, A delta, A gamma, A delta, and we have then B fibers and C fibers. So when you take the A fibers, so we have something called A alpha. So what are the A alpha fibers? These are supplying the motor supply, which means they are the motor neurons that are supplying the extrafusal fibers. We'll see what are extrafusal and what are intrafusal. So they're going to supply the extrafusal fibers, but anyway, they're motor to the muscle only, skeletal muscle. And this A alpha fibers are also going to, some of the fibers are also going to take care of the proprioception. These are also alpha fibers only. And some of the fibers are also going to come from the joint sensation. So proprioception from the joint. So this proprioception I'm talking about, the first one is the general proprioception from the muscle. And second one, they also carry the proprioception from the joints. That's called a joint sensation. So we know that. So, we can integrate the sensory classification along with this. For example, when you take the sensory classification, we have the size classification on the left side. There's a size classification. And based on the sensory classification, we all know that the first one will not come under sensory classification because this and this are the sensations. So I can write these are 1A and basically these are 1B fibers. So there is 2 different classification systems, and we are trying to integrate them. So the general proprioception from the muscle will be 1A fibers according to the sensory classification, and the sensory innervation of the joints, that is joint proprioception, will be carried by 1B fibers. In general, these are sensory from muscle spindles, because they are coming from the muscle proprioception, and 1B, they are sensory from the Golgi tendon organs, GTO. They're coming from the joints. And once I draw the diagram, it will become a little easier. So then we have A beta fibers. Still they are A fibers only, but what are A beta fibers? A beta fibers are going to be typically going to carry proprioception. Once again, a general proprioception, but that's not really important. But more importantly, they're going to carry certain sensations like touch and pressure. And these fibers, of course, you can see all are basically sensory only. So touch, pressure, proprioception. And these fibers will be called as 2 fibers according to our sensory classification. And we have A gamma fibers. As far as the A gamma fibers is concerned, they are going to be motor from the intrafusal fibers, which means they are going to supply the motor stimulation to the intrafusal fibers. That is the muscle spindles. Intrafusal fibers, not to the extrafusal fibers where you're talking about. Intrafusal fibers, whenever I tell intrafusal fibers, it means I'm talking about muscle spindles. They are the sensory organs of the muscle. So of course, you will not have any sensory system here because it's a completely motor kind of innervation. So then we have A delta. So as far as the A delta is concerned, they're going to carry some amount of pain. They are also going to carry a little bit of fine touch. And at the same time, they can carry a little bit of temperature sensation. What temperature? They'll be carrying the cold temperature because they are not known to carry hot temperature. And this is a question once upon a time in physiology, maybe 3 years back. So they're the cold temperature only. They're not going to carry hot temperature. And of course, you can see that all these are basically sensory only. Fine touch, pain, cold temperature, all these are basically sensory. So they should be classified under the sensory system. So they'll be called as fiber number 3. So that's how they're going to call it as. Then we have the type B fibers. Now we are going to B in the size classification. Once you go to the B fibers, this will be preganglionic autonomic fibers. They are going to be the ANS system. So we have both sympathetic system and parasympathetic system. For both the systems, we have ganglia, and before the ganglia, we call preganglionic, and after the ganglia, we'll be calling them as postganglionic. So these are the second order neurons we are talking about, the preganglionic neurons. And basically, they are B fibers only. And they'll be very little myelinated. They'll be still a little myelinated. It's not like they're unmyelinated. So they'll be still be a little white only, because whenever it's myelin, it's white. So these are also white. And in the spinal cord, they are called as white ramus communicants. We know that because they are myelinated, and because they don't have any sensory innervation, so they'll be just not be classified under sensory system. And we have type C fibers. Type C fibers are basically postganglionic autonomic fibers. So again, these are the third order neurons we are talking about. So for example, in the spinal cord for the sympathetic system, if you talk about these fibers will not be myelinated. We know that. So that's why they are basically called as gray ramus communicants. You would have studied in the spinal cord. But nevertheless, so that's that kind of elementary anatomy we don't need right now. So anyways, these are postganglionic autonomic fibers. And of course, they can also carry other sensations like olfaction. Even the smell fibers are basically C fibers only. And they can also carry that kind of a deep pain, visceral pain. So the dull aching, visceral pain and all this stuff. And they can also carry temperature, which is nothing but cold and hot. Both cold and hot temperature are basically carried by the C fibers only. So what you can really see here is they are the ones you can imagine that they can form the spinothalamic tract because they carry the pain and temperature. They are evolutionarily old. That's why they are unmyelinated. And even spinothalamic tract is also evolutionarily old. And you can relate them. So these fibers are the ones that are going to form future spinothalamic tract. Most of these fibers, even though there are substantial overlap at the level of spinal cord, but these are the fibers that are basically going to form the spinothalamic tract in the spinal cord. And of course, you can see that these fibers that are basically carrying this pain and temperature should be classified under sensory system. So I can write these fibers that are carrying pain and temperature that are classified under sensory system as fiber type number 4. So we have 4 types of fibers, as I told you. I think I should have write 4 here. So 1, 2, 3, and 4. And we have 3 fiber types based on the size, that is A, B, and C. And this forms the basis of understanding peripheral neuropathy. So because whenever you take an axonal type, yeah, visceral pain from the stretch receptors in the GIT. Yes, of course. So you have 3 types, A, B, and C. Of course, A is going to be the largest and C is going to be the smallest, and A is completely myelinated and C is unmyelinated, and B is okay, it's moderately myelinated. And in the sensory system, we have type 1, 2, 3, and 4, and that 1A, 1B, 2, 3, and 4. So 4 types of fibers are there, and how to integrate both of this classification system into one particular system, I've told you. So both are some different systems, but it's important to know that they'll be classified under one system. So to position these fibers properly, especially the motor fibers, you need to know basically the reflex arc. So what is the reflex arc? We know that you have studied this kind of diagram from the first year level itself. This is a very first year elementary physiology diagram that is sometimes asked in clinical medicine exams. So we know if you take the muscle, you have the intrafusal fibers and the extrafusal fibers. For example, I can draw, this is an example of a muscle spindle. You have something called a nuclear bag fibers and you have a nuclear chain fiber. So this is a bag fiber and this is a chain fiber, right? And these are basically what we refer to as something called intrafusal fibers, or simply we are going to call them as muscle spindles. And of course, they're going to receive innervation. They're going to take the sensation from these areas because these intrafusal fibers are the muscle spindles. They are the sensory organs of the muscle. They are the ones that sense how much amount of muscle is getting moved, how much amount of muscle has to be moved, and all these things, the information will be going to the brain through this intrafusal fibers, that is the muscle spindles only, because the brain needs to know consistently how much movement I'm doing. For example, if I want to take this water bottle and drink again, I want to open it, and if I want to go closer, I need to know how much my muscle is contracting. Otherwise, I'll overshoot, I'll hit here, or I'll be staying here itself. So I really need to know how much muscle movement should happen, which means every single microsecond, your brain will be receiving inputs. Different areas of the brain will be receiving inputs about where the muscle location is and how much movement should happen, whether that movement is necessary or not. All these things will be done by the intrafusal fibers. They are the basic sensory organs of the muscle. And all this information is going to go into the spinal cord. We know that. So if you take, this is the posterior, this is the anterior, and all this information has to go to the spinal cord. So in the sense, like, for example, we can write that these are fibers that are moving towards the spinal cord. And everyone knows what these type of fibers are, which are basically sensory from the muscle spindles. What are these fibers? What are these fibers? I mean, it should be easier to answer, isn't it? What are these actually type of fibers? These are A-type fibers only. This will be heavily myelinated, but because they are sensory, it should be typically called as something called a 1A type of fibers. These are basically 1A. All right. And remember, most of these fibers, even though in the reflex arc it will not be mentioned, most of the fibers actually are ascending as the posterior column above because they have to go to the cortex and the cerebellum to correct the movements voluntarily and involuntarily regarding how much amount of movement should happen. But as far as a reflex arc is concerned, there are some amount of fibers which are basically going to come directly into the anterior horn cell. Maybe I can draw a little better. So they're going to move to the anterior horn cell area. So in the anterior horn cell area, they're going to directly synapse with the anterior horn cell. But please don't take this for granted because there are a lot of fibers basically that are traveling up as the dorsal column towards your brain to give information to the brain. But currently, since we are concerned about our reflex arc, you can understand like certain percentage of fibers, like 5% or 3% of the fibers are going to take a shortcut route and they're going to directly innervate the anterior horn cell. And let us understand the importance of the reflex arc later on, but still there are some fibers which are going to directly innervate the anterior horn cell fibers. And from the anterior horn cells, you're going to get certain motor fibers that are basically, I think, two types of motor fibers. One is going to be the motor to the extrafusal fibers. And second one, they also have motor to the intrafusal fibers. For example, there are two types of fibers which I can draw from the anterior horn cells. One is the fibers that are traveling to the intrafusal fibers, and second one, they are traveling to the extrafusal fibers. You know what are these fibers as? The motor fibers to the extrafusal fibers to the ordinary skeletal muscle will be called as A alpha. That is what we refer to as alpha motor neurons, and the motor to the intrafusal fibers will be calling that as A gamma fibers or gamma motor neurons. You know that. So there are very less number of fibers that are going to actually supply the intrafusal fibers because the number of intrafusal fibers are basically less. But alpha motor neurons are going to be very, very high in number. That's why I drew in dotted lines as well as in the thick lines here. And apart from, I mean, this forms the basis of very simple reflex arc. And what is the basis of this reflex arc in the first place? Suppose if you have a low threshold stretch, I mean, it is only, the only way to understand reflex arc is this, because there are a lot of controversies regarding why a reflex arc is present in the first place, because there are so much of theories are there. But this is one of the widely accepted hypotheses. For example, if you have a low threshold stretch that is happening, for example, maybe a small stretch that is happening, and that is happening involuntarily without the help of the corticospinal tract. And this kind of stretch is basically not required because, according to our modern evolution, everything and anything should happen consciously with regards to skeletal muscle, and nothing should happen unconsciously. So, for example, you don't really go to the next house and put the calling bell unnecessarily, isn't it? So that is, you cannot do that involuntarily. So which means, as per the corticospinal tract's rule and as per the evolution, everything should, as far as the skeletal muscle movement is concerned, it should be involuntary only. And these kind of small stretches and involuntary stretches should be counteracted, and that is why we have a reflex arc. That's number one idea, which means it should be very clear that your corticospinal tract is basically going to inhibit this kind of a reflex arc, and they're not really going to encourage any sort of a reflex arc, which means this kind of reflexive movement should be avoided. And at the same time, anything that is involuntary, that is happening without the information from the cortex, also should be contracted. So that is the basis of the reflex arc. For example, if there is a small stretch in the muscle and that is happening involuntarily without your knowledge from the cortex, so that reflex, which is not able to reach the cortex, and at the same time, if that reflex is happening without the knowledge of the cortex also, that stimulus will be carried by the 1A neurons directly to the anterior horn cells, because that low intensity stimulus is not enough basically to reach the cortex. So it will reach the reflex arc, it will come to the spinal cord, anterior horn cells will be stimulated, and directly your alpha motor neurons will be stimulated, and the muscle will contract, and that stretch will be neutralized or contracted. This is the most accepted hypothesis for the reflex arc, even though a lot of controversies and different forms of why the reflex arc exists is still there in the different textbooks. But nevertheless, you have another different kind of movement that is happening. So that is called as GTO reflex. That's a Golgi tendon organ reflex. Everyone knows that from the tendons, you have this 1B neurons that are going to go into the spinal cord. These are the 1B neurons. These are coming from the Golgi tendon organs. These are sensory from the Golgi tendon organs. And they don't reach the anterior horn cell directly. Instead, they're going to reach the anterior horn cell through an inhibitory interneuron. So I can draw it in red, sometimes called as Renshaw cells also. So this is an inhibitory interneuron, which means this is an inhibitory neuron. So whenever the Golgi tendon organ reflex is stimulated, your interneuron will be stimulated, which means the inhibition will increase. So which means the anterior horn cell firing activity will basically decrease in this particular setting. So which means this kind of GTO kind of a reflex is basically trying to relax the muscle rather than contracting the muscle. So that is the reason why it is called as a inverse stretch reflex. It's not a basic stretch reflex. So you have two things. One is the basic stretch reflex, and second one is what we have as the inverse stretch reflex. Inverse stretch reflex. So as far as the stretch reflex is concerned, we know it's going to contract the muscle in response to stretch, and inverse stretch reflex is basically going to relax the muscle. And these are basically coming from the intrafusal fibers. These are basically based on intrafusal fibers. And the reflex, the afferent is actually coming from the Golgi tendon organs. These are 1A fibers. These are 1B fibers. And there is, it's a monosynaptic reflex. We know that stretch reflex is basically a monosynaptic reflex, a simple stretch reflex. It's happening at the spinal cord level. Whereas inverse stretch reflex is a bisynaptic reflex. It's not a monosynaptic reflex. There are two synapses here. You can see one with the interneuron and another with the interneuron and the anterior cell. So you have two synapses here. So it's a bisynaptic reflex basically. So stretch reflex counteracts any sort of stretch, but inverse stretch reflex is thought to be protective at stretches which is going to happen at the supra threshold level. I mean, in the sense like at the super maximal level, when the muscle is, going to tear if it's going to cause any more contraction. So in that setting, you will result in the development of an inverse stretch reflex, which is basically thought to be protective and it's going to basically relax the muscle rather than contracting the muscle. But nevertheless, all these things should happen without the knowledge of the corticospinal tract. Then only these reflexes will have a value. If it happens with the knowledge of the corticospinal tract, so these things are not going to have a value. So for example, if somebody is massaging you in the massage parlor and you know that they're going to massage you, and whenever they massage you, you voluntarily relax your muscle. You don't really stretch your muscle. You don't really contract your muscle. That stretch reflexes will be negligible. So, and again, that stretch is happening with the knowledge of your cortex and with the permission of your cortex. So in that setting, these stretch reflexes will be completely abolished. We know that because their relaxation and contraction, everything is happening under the cortical influence. When cortical influence is not there, and when you're doing this kind of a small kind of a stretch, so they are going to elicit a stretch reflex. So this is the basis. Don't think like extravagantly, and these stretch reflexes are very important. So that is the reason why whenever you do not have influence from the corticospinal tract, so your stretch reflex will be basically released in the sense like they'll be too much and they will be exaggerated. So that's what is going to happen. So whenever you have a UMN, you tend to have a increased deep tendon reflex, which means compared to that of baseline value, it's going to be a little higher. So that's what we call it as an exaggerated or a brisk deep tendon reflex. That's what is going to happen because the cortical influence is gone there and they become a little bit more hyperactive. And at the same time, deep tendon reflexes will not cause any kind of atrophy because this is still intact, which means the anterior horn cell supplied to the extrafusal fibers and intrafusal fibers is still on. So in the sense like the nutritional supply to the muscle and the stimulation to the muscle will not be reduced at all in the first place. And that is also one reason why your atrophy will not happen unless until the patient goes for a diffuse atrophy. There will not be any atrophy in the human. And at the same time, because the anterior horn cells are released from basic inhibition, you can imagine like only from the order from the cortex, your anterior horn cells should fire. The rest of all the times, your anterior horn cells will be kept under a baseline inhibition. But still, they will have some baseline, tone. In the sense like baseline firing will still be there for all the neurons, but the corticospinal tract tries to keep it under a little bit of suppression. So once the corticospinal tract influence is gone, so your tone is going to definitely increase. So rather than imagining like a absent tone or a present tone, it's like a baseline tone is there for the anterior horn cells, and even for the muscle, you have a baseline tone. And if somebody asks you what is tone, if you want to tell in one sentence what is tone, it's nothing but a state of resting contraction of the muscle. Even at rest, even during sleep itself, except for the REM sleep, even during sleep itself, you have a baseline tone in your muscle. That is because anterior horn cell has a baseline firing rate that's going to keep the muscle in a baseline state of contraction. The tone will be there. So as usual, the tone will be increased here for sure. Elements are going to be completely opposite because in element, the problem is either in the anterior horn cell or the problem is in the peripheral nerves. So peripheral neuropathy. So this is element basically. So as far as the element is concerned, what you're going to really get is a suppressed DTA because this reflex arc is completely disturbed. So you'll be resulting in a suppressed or an absent DTA. And at the same time, you're going to result in severe atrophy because now the stimulation from the anterior horn cell is gone whatsoever, and even the baseline stimulation to the muscle will not be there. So they will be deprived of nutrition and all this stimulation related trophic properties, and they will go for atrophy. And of course, the tone will reduce and the muscle will go for flaccidity. And other things, if you want to know, of course, we'll see later on why you see fasciculations. So you can see either fasciculations or something called fibrillations in an element lesion. Depending on where the level of lesion is, anterior cell lesion typically produces fasciculations, and peripheral neuropathy, peripheral nerve lesions typically result in development of fibrillations over a period of time. And here, one more additional finding that you will see is Babinski. That is plantar extensor response. And there is a lot of theories again for plantar extensor, and which is inappropriate to learn at this point of time. There is absolutely no reason to know why Babinski is happening, even because even neurologists are very confused why Babinski is there in the first place. But still it is considered, I mean, the basic plantar response is considered to be a protective response for any kind of noxious or a painful stimulus to the soul. But Babinski is something that is present in the, like older animals. Evolutionarily, it is lost because of the corticospinal influence. Now, once the corticospinal tract influence is gone, Babinski will be released once again, and we are going to behave like the older beings in the evolution. Fine, all right. So, but the most important fact here is to understand